update. I hoped I hope that you had some time to have a look at it, so you get key figures already assimilated. But we will go a little bit more into what this really means, as well as other issues about health workers and impact of COVID-19 on health workers and what WHO is doing to protect them. So as we have announced in our media advisory, we have three guests with us. We have Mr. Jim Campbell, who is our Director for Health Workforce. We have also Dr. Anne Perrochot, who is epidemiologist here at WHO, and we have Professor Benedetta Allegranzi, who is technical lead for Infection Prevention and Control Hub. So I think we will start first with Dr. Campbell, who will tell us a little bit of overview of the impact of COVID-19 to health workers. Then we will go to Dr. Anne Perrochot, who will explain us how we got these figures and what these figures tell us. And we will conclude opening remarks with Professor Allegranzi, who will tell us about what are the risk factors for infection of health workers and what WHO is doing to help health workers protect themselves. Then we will open the floor for questions. So I will give the floor now to Mr. Jim Campbell, Director of Health Workforce here at WHO.
Thank you, Tarek. Thank you, Tarek. Good morning, good afternoon, good evening. Jim Campbell. Obviously, I mean, you have the latest update issued on the global epidemiological situation, and we can see clearly a pattern across the world and the WHO regions that we are continuing to see increases. Healthcare systems and health and social care workers are faced with the challenge of responding to the pandemic, maintaining the delivery of essential health services, and thinking forward to the potential availability of a vaccine and the preparation of the vaccine and immunization options. This is putting a significant demand on the capacity of our health and social care workers worldwide, the impact of which is extensive. We're going to be talking today in particular about infections in healthcare workers, infections in both health and social care settings. But some of the other impacts that we are following as WHO, working with member states, is around the existing shortages in the health workforce. Many countries already facing challenges in the number and the skill mix of workers available to provide primary healthcare, universal health coverage. We're seeing the challenge of extensive redeployment of staff to manage the pandemic and the impact that has had on maintaining essential health services. Nearly 100 member states reporting that essential health services are being disrupted because of this redeployment challenge. We're seeing the impact of not necessarily with confirmed infection, but with possible infections, isolation and quarantine, which takes people away from the workforce, especially if testing is not available. This is having a detrimental impact after 9 months on mental health. It's the burnout, the stress, the anxiety that we're seeing amongst our healthcare employees, and how they have the motivation and the commitment and the dedication to continue in their work when they're faced with these many difficult challenges. We're seeing around the world the manifestation of this into industrial action. We're seeing labor disputes and even strikes among certain occupations. We saw here recently in Geneva a similar manifestation around some of these issues from health workers in one of the main hospitals. That's also then translating in the intention to leave. Many studies and qualitative assessments coming out suggesting that people are so burnt out, so much stress that they may be leaving the profession. And that has consequence when we go into next year and the realities there. We've seen that, though, the positives. We've seen applause and recognition and awareness of the role of health workers around the world, from leaders, from the general public, through art, through film, and through social media. We're seeing respect and recognition of our healthcare professionals for their essential work in protecting the public, managing disease. But we also have to be aware that applause without action is not good enough. That respect and recognition without rights and reward and remuneration is also not going to lead to long-term sustainable improvements in our healthcare settings. We will hear in detail about the infections from my colleagues, but I think there's one key message that we are seeing coming through the data that we've analysed, and this is from the member states' reports. It is clearly a continuing challenge, and we need healthcare systems to respond to that challenge. But overall, the trend is encouraging. You know, where we have data, we're starting to see the impact of guidance, training, supply chains, and the improvements in clinical practice. But we still need to do more, and my colleagues will expand upon that. We heard in the executive board special session that was held last week, member states reviewing and looking at the lessons learned and the elements that can improve our response to the pandemic going further forward. We had a recommendation from the Minister of Health in Turkey that we need to make 2021 an international year of health workers in recognition of their efforts. And that proposal from Turkey will continue to be a discussion amongst member states. But I think one of the key things we need to do now is to make sure that we do take positive action to address the multiple impacts upon health workers. Like I said, their mental health, their stress, their anxiety, their rights, their rewards, at the same time as managing infections and the pandemic. Thank you very much. Happy to take questions when we finished the presentations.
Thank you very much, Jim. Now we will turn to Dr. Anne Shaw, who is working as epidemiologist here at WHO and in the surveillance unit. So she will tell us more about the data that you have already seen, published last evening. Anne, please.
Yes, good afternoon. I will first indicate the origin of the information we are sharing here, and then go through the result of the analysis that were conducted. So as early as January 2020, WHO set up a global surveillance system, so to collect minimum information, to monitor the trend of the epidemic, and also to describe and understand the epidemic pattern and transmission. Then we use what we call a case report form with minimum information. And as of 15 September, the case report form database contains as much as around 8 million forms, which represent around 30% of all cases recorded at date. There is a participation of more than 150 countries in the case report form surveillance and weekly surveillance together. So we conducted an analysis of health worker information over close at 300,000 health workers reported from 83 countries. And this represents the data which are covering primarily Europe and American countries, estimate that around 40% of COVID cases reported to WHO are identified as occurring in health workers. There are large differences between countries. However, the overall mean estimate of infection among health workers illustrates an overrepresentation of cases, given that the health workers represent less than 3% of the population globally, and less than 8% in average in high-income countries. So the data analyzed indicate that there was a substantial decline in health worker infection over time since the start of the pandemic. And in the last months, we were showing that the proportion of cases among health workers were closer to the share of the general population. In terms of age and sex, we observed the data show that the mean age was 40 years, which is lower than the mean age of non-health workers, which is 46 years. Distribution of health workers in women, 67%, is proportional to the global share of women and men in the health workforce as usually reported. Then, for a selected number of countries with high-level quality data and completeness, meaning when we have a report on more than 70% of case reporting by the country and the information is completed for more than 75%, we were able to compare the proportion of COVID-19 cases for comorbidities, hospitalization, and deaths by age category and sex. And what we show is that 13% of health worker patient reported underlying condition, and this proportion is lower than what is observed for non-health worker in those countries. Also, 5% of health workers require hospitalization, and this proportion again is lower than the one observed for non-health worker reported in the country. Overall, 0.5% of health workers were fatal, and this proportion once again is lower than expected for the population of non-healthcare workers. Differences are really pronounced for patients over 50 years of age and above. We are now conducting more analysis to understand those differences and try to better describe the pattern of infection of health workers and the setting of infection of health workers. Happy to take questions after it. Over to you.
Thank you, Anne, for these explanations on figures. I will now give floor to Professor Legancy, who will tell us more about risk factors for COVID-19 infection among healthcare workers, and also what WHO is doing to train and help health workers protect themselves. Professor Legancy.
Thank you. So WHO has worked with the University of Oregon to look at the available evidence and literature published on different coronaviruses and really focusing on COVID-19 in particular to better understand this data and especially how health workers get exposed and infected. This work has highlighted that infections can occur in both acute and long-term care settings, also in outpatient settings, and infections are transmitted from patients and residents to health workers, but also between health workers. And this work has also shown that there are specific situations that are obviously at higher risk, in particular during care situations like involvement in intubation of patients, direct patient contact, and also contact with body fluids. But also a very important risk factor is inconsistent or incorrect use of personal protective equipment, various types of these equipments. Another element which is really important emerging from recent publications from different countries is the fact that it appears that health workers could get infected also in break rooms, during their social life, in common areas within healthcare facilities, as well as quite prominently in their households, so in the community. So there are new studies emerging from the Netherlands, from the US, from Germany, documenting these situations I just mentioned. On the other hand, very importantly, from this living systematic review and meta-analysis, we know that appropriate personal protective equipment use, hand hygiene best practices, policies and implementation of universal masking within healthcare facilities, and appropriate and adequate infection prevention and control training are all measures and factors that significantly reduce healthcare workers' infections. So my colleague has just talked about decreasing trends in health workers' infections over time, fortunately, since the beginning of the pandemic. We believe that this reflects a better approach and implementation over time of these measures by member states, by facilities, local governments, and also it may reflect the WHO actions in this field. So indeed, we have obviously recommended that there are specific measures starting from having infection prevention and control programs and occupational health programs in place at the national and the facility level as being very important, a very important factor, especially when reflected in policies and implementation of standard operating procedures. In particular, these procedures need to be related to screening, triage, early recognition for health workers in particular, syndromic surveillance and testing in specific settings and according to a risk-based approach, and systems for managing exposures as well as infections. There are other, obviously, measures, in particular, the type of personal protective equipment to be used and also the behavior to be taken during provision of care. In particular, obviously using standard and transmission-based precautions, but also continuously wearing a medical mask or a respirator, depending on the situation, frequently performing hand hygiene, keeping physical distance as much as possible during activities. And as I said, very importantly, refreshing IPC education. Another aspect that my colleague Jim Campbell has highlighted, and it's very important, is staffing levels. Already in 2015, WHO recognized that having low staffing levels and high workload was a risk factor for transmission and spread of outbreaks in healthcare facilities. And therefore, we recommend adequate levels of these. So in all these fields, in conclusion, WHO has produced, of course, many guidance documents. We have overall 16 guidance documents on infection prevention and control. WHO has established a COVID-19 educational channel, which hosts nowadays 121 courses on COVID-19 and in 39 languages. And there have been, until the end of August, more than 4 million participants in these courses. And finally, WHO has established a supply chain system which in a few months provided 172 countries with millions and millions of items of personal protective equipment and hand hygiene supplies. And last but not least, of course, our regional offices and country offices continuously provide technical and operational support to all countries affected. So this is what I wanted to explain, and I'm very happy to provide more details later.
Thank you. Thank you very much, Professor Eleganzi. So we will now start with the questions. First question is Jérémie Lanche from Radio France Internationale. Jérémie?
Yes, thank you, Tarek. Just want to ask first, can I ask my question in French and maybe get an answer in French? I'm looking at Anne right now, and yes, she says yes.
Okay, go ahead.
Je voudrais avoir une... Alors, la question s'adresse à plusieurs personnes, mais peut-être Anne, vous pouvez répondre. Vous avez dit un petit peu plus tôt, je crois que c'est monsieur au panel, qu'il y avait cette tendance que beaucoup de personnel de santé étaient au bord du burn-out. Il y avait cette tendance que beaucoup étaient sur le point, avaient manifesté en tout cas leur volonté de quitter leur métier à cause de la situation, à cause de ce qu'ils ont vécu ces derniers mois. Je voudrais savoir si il y a est-ce que c'est simplement un sentiment un petit peu dans l'air comme ça, ou est-ce que vous avez des éléments qui arrivent à étayer ça, dire que des chiffres, je ne sais pas, est-ce qu'on sait que ça concerne certains pays en particulier, certaines catégories personnelles, est-ce que ce sont des infirmiers? Enfin, voilà, est-ce que vous pouvez élaborer un petit peu autour de ce ras-le-bol et autour de la profession? Merci.
Oui, merci pour la question. Je préférais passer la question à James. Je vais lui traduire parce que en termes de cette analyse plus globale de ce qui est en train de toucher le personnel de santé, je pense qu'il a des informations qui sont...
Non, just answer in English. Yeah. Jérémie, donc voilà, Mr. Campbell will answer in English, and if needed, I can translate.
Merci, Jeremy. Indeed, you heard from Benedetta here, the systematic reviews, live systematic reviews that are ongoing. And in the surveillance updates, we talk also about the necessity to have standardized reporting and measurement on some of these impacts. We are seeing an increasing number of journalist and media reports and some studies by professional associations in some of the OECD countries where this intention to leave, burnout, leadership responses to questions around what is their biggest concern in the next 12 months, all pointing to an increasing level of stress, anxiety, burnout in the workforce, and professionals themselves and students indicating they are seriously considering leaving the profession. We're underway with a much more structured review to identify this, but these are publications, like I said, from journalists, media, peer-reviewed literature, mainly from high-income countries, and we're trying to ascertain better information around the world.
Thank you, Jim. Jeremy, would that be okay with you? I hope it will. Otherwise, we can organize something after the briefing and have something properly in French. Let us go now to Isabel from EFE. Isabel.
Yes. Good morning. Thank you, Derek. I would like to come back to Dr. Perucho's numbers presentation, because I had some difficulties to understand all the numbers and data she gave. For example, she mentioned that what I understood is that your study took into consideration 300,000 health workers in 83 countries, representing mostly Europe and America. I would like to, for example, to understand in America, you are meaning North America, Latin America, or overall America? And what about Asia? Why not Asia or China, where was in the first in this pandemic, and maybe you could have more data on, about what happened in this country. Why you don't consider mostly Asia too? And also, if she can repeat some of the comparisons she made on the infection overrepresentation cases, and what she said about the declines that we are witnessing, for example, in relation with infection in health workers and infection compared with infection in overall population. And finally, if she can clarify also, because she said that health workers requiring hospitalization and the fatalities was less than in the general population. But she said also that the average age of health working infected is less. So it could mean that they are younger, so they have less mortality and less lethality, sorry, and less severe infection. If she can please clarify all this data, because it's very important to understand very well this.
Thank you for all these questions, Isabel. Let's just try to answer some of them, because I just see there are so many journalists online who are waiting to ask a question. And
yes, I will try to make it short. So regarding the first question, which country are we talking about and who is reporting? So as I mentioned, there is a overall system, global surveillance system, that is requesting via the international IHR, International Health Regulation, that all countries report to WHO a minimum set of information on all cases that are reported at national level. Countries are participating to the global surveillance according to different criteria and patterns. What we observe is that many countries in Euro and PAHO are participating. When I say PAHO, I say North and South and Central America. And we also have countries from MRO, CIRO, and WIPRO. I'm mentioning WHO Regional Office here, but in a less extent. So we can say that our data represent mainly PAHO and Euro countries. However, we also are presenting data from CIRO and WIPRO. But as I say, not all countries are reporting to WHO, even if we are trying to make all efforts so to get a comprehensive reporting from all countries. And even if country is reporting, they might not all have the information on health worker at national level. So country reporting all cases might not provide information on health workers just because they don't have it collected at the national level. So they are sharing with us what they do have. And so this is the cause of the differences we observe in the reporting of health workers. So we're talking about 83 countries reporting healthcare workers, but we know that majority of countries are in Eastern and in Euro and PAO regions. So I hope this responds. Now, when we talk about the decline in health workers in proportion over all cases, we are expressing here that what we observe in the first month of the pandemic, the proportion of health workers reported to the case report form where the information is the patient healthcare worker, yes or no, is documented, has shown a decreasing trend over time. So even in countries and in regions where the number of cases has been increasing over time or has been, as the trend we know, we observe a steady decrease in the reporting of healthcare workers, in the proportion of healthcare worker reporting. So this might be linked to awareness, but also better protection of health workers. Now to the last question, what we did, and you can read it in the AP Bulletin, is that we compare for countries with high quality data, the health worker versus not health worker by age and sex. This is to control to exactly what you said, that maybe if they are younger, they have less comorbidities. What we observe is for all ages, there is a lower proportion of health workers reporting comorbidities than non-healthcare workers. And this is the same for hospitalization and for deaths, meaning that health workers are less likely to be hospitalized at any age and for male and for female than non-healthcare workers. So is it a healthy working effect? Is it because they are captured earlier in the course of the disease? Or is it because of testing strategy that sometimes capture positive cases that are not expressing disease and will not develop the disease? This is under investigation at the moment. So I hope I have one.
Thank you, Anne. Hope this covers at least some of the questions that Isabel has asked. Next question is from Jamey Keaten from Associated Press. Jamey?
Can you hear me?
Yes.
Great, thank you for taking my question. I wanted to just try to get, the numbers are kind of going everywhere, and I want to just make sure that I understand the overall value judgment, if that's possible, on these numbers. For example, it sounds like you're saying there's a significant decline or a considerable decline, if I understood you correctly, in terms of the numbers of health workers being infected. So I just want to make sure, do you have a global percentage of health workers who are getting infected? Is it going up or down? And are these people who are getting infected at work? And then a second question is just about, in terms of, now that masks are being recommended by everyone, including WHO, are you seeing any shortages of PPE for healthcare workers, whether it be masks or gloves or anything like that? What can you tell us? Thank you.
Thank you. Jamey, I don't know who would like to ask the first question, answer the first question. Anne, would you like, or Jim, would you like to take the first one? And I think maybe the second one, Benedetta can deal with.
Okay, so for the first one, the prevention of health worker, so as mentioned earlier, this information is what member states and countries are reporting to WHO on the basis of information for every patient that is collected. And so the proportion of health worker that is reported is decreasing with time. So it's a proportion over the number of case report form with information completed, is the patient healthcare worker, yes or no? And so this completeness of information is stable over time and is showing that the proportion of those that are reported as health workers is decreasing steadily with epidemic going on. So for your question, is there a decrease in health worker reported? Yes, as infected by COVID-19, for the data collected for the surveillance, yes, there is a decrease in the number of, or the proportion, let's say the proportion of health worker reported among the case with the information. I hope I respond to the question.
No.
In the document.
Thank you. Benedetta, would you like to take a mask? And for you, Jamey, you have on the next page of the you have a graph basically that shows the decrease of proportion of health workers among infections. Benedetta.
Yes, thank you for the question. So first of all, of course, WHO has always recommended medical masks and respirators depending on the situation since the beginning, since January. What has changed for WHO recommendations and also other organizations is that between May and June, we have started to recommend continuous use of masks within healthcare facilities, in particular in clinical areas, by any health worker instead of only those who provide care. So just a clarification on that point. So it has been some months now that there is widespread use of masks in affected countries in healthcare facilities in particular. Over time, as you know, there have been shortages in many countries, including high-income countries, just for due to production gaps, basically, because the entire world has been caught unprepared with the the demand of PPEs in general, but masks in particular. Shortages may still happen, but certainly the production has been scaled up immensely over the last 6 months or more. And in addition, as I said, in particular for low middle income countries, which certainly have financial issues, procurement issues, WHO and other institutions have set up this supply chain system which efficiently works. And I can inform you that as of end of August, there were 101.1 million medical masks and 18.2 million respirators shipped to different countries through this supply chain system. So certainly there have been many efforts to mitigate this problem, but I think we need to be aware that this may happen again or be happening now in specific local situations. So there is an important aspect that needs to be continuously raised to countries, governments, procurement systems, for them to be always alerted and continue to procure regularly good quality personal protective equipment. This is certainly very important. And just to, maybe another piece of information, WHO as well as CDC and ECDC have issued documents about rational use of personal protective equipment, where we give a number of suggestions to avoid to get into this situation in terms of shortages. There are many strategies that can be put in place either to prevent or to cope with similar situations. Not always optimal, but certainly now we have advanced a lot. Also, for instance, in research that WHO has facilitated and funded in terms of methods to reuse safely reprocessed personal protective equipment in some cases, or research on extended use of masks, for instance, for multiple hours. And these are all measures that should be put in place in very emergency situations where there is real shortage.
Thank you. Thank you, Benedetta. Now we will go to the next question. That's Gabriela Sotom from Proceso, Mexico. Gabriela.
Thank you for taking my question. I have two questions or three, I don't know, but one is who is going to held accountable for the deaths of health workers that the governments are failing to provide PPE? Because, for example, in Mexico, it's a scandal. So that is another question, if you can talk about Mexico's situation. And because in conflicts, it's very clear what are the rights of the health workers and all that, but who is going to protect them in this situation? And I think that's it. Thank you.
Thank you, Gabriela. Indeed, we've been following the example that you mentioned in the media and the news and the information and the data with great interest. WHO very early in the pandemic this year issued guidance on the rights, roles and responsibilities of health workers, and with a particular emphasis on occupational safety and health. And that set out the normative work and the considerations, including reference to all the international standards and conventions around employment and labor and occupational illness. An updated version of that guidance is currently going through the internal review process, and we anticipate will be published in the next few weeks. And that will provide that. What we can do is ensure that we follow up with you, that you get a copy of that guidance as soon as it's published. And I think many of the particular issues that apply to within a jurisdiction can be referenced in that guidance and normative work. Empathy, obviously, with any health worker that's been infected and those who have lost their lives. And indeed, there are employment legislation, occupational roles and responsibilities that do apply.
Thank you very much, Mr. Campbell. We will go now to John Zarocostas from Lancet. John?
Yes, good afternoon for this briefing. I've got a couple of technical questions with reference to the number of health care workers that died. Is that basically from the sample of 5 countries only and not necessarily from the data of 83 countries? And my second question is, how many countries from the Western Pacific are included in your survey with hard data? Does that include Japan, South Korea, China, and Australia, for instance?
I think this for me. I'm not sure I fully understood the first question. Please, can you repeat?
Yes, can you hear me?
Yes.
Yes. The number of deaths, I think it's, you mentioned 0.5% that have died. Is that basically only from the selected sample of 5 developed countries? And that's not necessarily from the global data set?
Yes, correct. We conducted more precise analysis using the data from 5 countries where we have a good completeness in terms of number of cases reported compared to the total number of cases that occur in the country, and also a good completeness on the information healthcare worker, yes, no, and on those parameters as presence of comorbidity, hospitalization, yes, no, ventilation, yes, no, and what was the outcome. So yes, we conducted this analysis over 5 countries located in Europe and the America. So this is for the first, and it was over 1 million of patients reported with the correct information. Now, the second question is also, we'll say yes, without entering too much into details, but yes, countries such as the one you mentioned are sharing with us the information on with case report form. However, I cannot tell you now what is the proportion, which one are reporting on healthcare worker and which one are not, because some, as I mentioned before, some countries might not have the information, or sometimes just either do not collect or do not share with WHO, and so I will not tell you this one yes, this one no from in this meeting, but this information is available. But yes, we have the country, some of the countries you mentioned are participating in the global surveillance and sharing information with us.
Thank you. Next question is from Nina Larson from AFP.
Yes, hi. Thank you for taking my question. I had a few questions, actually. I was wondering about just on the question of the number of people who've died, do you have an estimate globally, sort of from your research, about how many health workers have died? I'm also wondering about the overall proportion that you were talking about 14%, and that it's been declining. Do you have sort of a proportion a few months ago and what the proportion is now? Maybe I've missed it. And also, if you could say something, if you have any idea of the proportion of health workers who've been infected in health facilities and in home settings, that would be helpful. Thank you very much.
Okay.
Thank you, Nina. Who would like? Anne, do you want to start? Maybe then Jim wants to add something.
Yeah. Okay, so I can start. The total number of people who died, I think this information, unfortunately, is not available at WHO level, at WHO global level, I would say. Information might sometimes be available in the regions, but there is still some difficulties to assess those number mainly due to the difficulty to report on outcome. This surveillance system is based on a rapid reporting of every case, so for the WHO to be able to monitor the trends. As you know, outcome, I mean, as if the patient died, recover, you need some time to identify what is the exact, how the patient will evolve with time. And so the completeness of the outcome is really poor in our database. And we will not rely on this database to provide a correct estimate of the overall burden of the overall deaths among healthcare workers. This database will not allow us to be precise enough, and this will necessitate further studies, specific studies. Besides some countries, as we were able to show here, that are sharing very high level quality data. So I think that's what I want to say. Now, regarding the proportion of health worker that as an overall is 14% of reported cases, we saw in the graph that is mentioned in the AP bulletin that at the end in June and August, this proportion now is 5%. So once again, with huge variation between countries, we observe for all of them that if they started with 20% sometime or 15%, they are now below 5% of infection occurring among healthcare workers. And I think
Thank you.
I will stop here.
Jim, would you like to add something?
Just Nina, just on the particular issue about the estimate globally, we again, I emphasize the point that we're trying to do standardized measurement and reporting, and we're following literature in peer-reviewed publications, as well as news and journalists, as well as member state reporting. One of the challenges clearly is that the difference is in reporting standards. So where our numbers are particularly where we've got consistency in reporting from member states to the same standard, and we can give that figure. We're aware of other estimates that have been published globally, but we recognize the numbers are high. But what we're saying is, and that we need to be taking action in response to reducing the level of infection and the risk to health workers, no matter what. But at this moment in time, some of the data that has been reported on global estimates is not necessarily following the same standard as WHO.
Thank you very much. And again, there is a graph, figure 9, in the epidemiological weekly update published yesterday that shows exactly this per month on percentage of healthcare workers' infections among overall number of infections in selected countries. We have Peter Kenny, and then we have follow-up from Isabel. Hopefully we will be able to finish with those two. Peter?
Thank you. My question concerns PPE fraudulence. At a press conference earlier this year, the Director General was asked a question from South Africa, which is a country I do reporting on, about PPE fraudulence and the results of it being tantamount to murder. Do you have any research on the effects of PPE fraudulence in any countries, including South Africa? And something that can be measured?
Peter, I don't think this is a question for our speakers here. So what I would like is that you send us an email, and we will look for people who in-house here who may have more on this topic. And now I will call on Isabel to ask her last follow-up question, and this will be last question for today. Isabel.
Yes, thank you very much. I would like to know if you could give, I mean, after all this analysis that you made on all this huge data, if you can give an advice, for example, on what is the maximum of patients that any health worker, wherever he or she is, can be taken care of. What is the really not to stress and to avoid burnout or any kind of situation, even if the situation in different countries we all know is different, but human being is human being everywhere. So what could you say is really the threshold, of this? Thank you.
Isabel, that's a simple question, but has a whole set of complex answers to it. Clearly, there is overwhelming evidence around safe staffing and its impact on patient safety, safe staffing numbers and the impact on workload, mental health, stress amongst the health employees. But these are across multiple settings, in acute facilities, in different types of wards, which are providing triage, in long-term care, et cetera, et cetera. We have some documentation on the safe staffing elements, which we can connect you to offline, but we don't actually advise a simple X amount of health workers per Y number of patients because of the complexity of the settings involved. But the principle of safe staffing and the impact of the evidence on patient safety and health worker safety is overwhelming in favor, and member states indeed, we recommend that they continuously consider, update and revise their staffing guidelines accordingly.
Thank you very much, Mr. Campbell. I don't see any more questions. So just like, if it wasn't clear, because I got a couple of messages, so there is no proper press release. And I think when we have a more comprehensive figures, we will do one. But for the time being, all these figures that have been presented have been published last evening in the weekly epidemiological update that is posted every Monday evening on our website, where we detail the number of COVID-19 infections. Now, every Monday we have a focus on something. So yesterday the focus was on health workers. This is where we publish the figures, and this is why we wanted to give you opportunity to ask questions on this. But this is on our website. If you go to WHO website on COVID-19, click on situation reports, and then you will have a weekly epidemiological review, and just click on one that is dated October 12th. That was yesterday. I wish to thank our colleagues from UNIS for technical support on this, and big thanks to Dr. Perechot, Professor Elegancy, and Mr. Campbell for being with us. For any follow-up questions, don't hesitate to contact media team, and then we will see you for the next WHO press briefing is tomorrow on tuberculosis at 2:00. Have a nice day.
Thank you, Tarek. Thank you, colleagues.